Hi, everybody. Welcome back to Indie Sage. I hope you've all had a great summer and everyone as well. We're now back from our summer break and we're going to be doing our fortnightly briefings from now on. This autumn, we're going to be covering learning from the last 3 years with a different topic each time. And today is going to be on airborne transmission. And in 2 weeks, we'll be looking at resilience to shocks, think like pandemics. Over the summer, we've continued to hear about pressures on our healthcare system, worries about how it's going to cope in winter. And the autumn flu and COVID vaccinations are about to start, but they're being offered to fewer people than last year. And in today's session, we're also going to be featuring a new regular segment called Situation Update on some of these kinds of topics. So to start it all off, I'm first going to ask Dr. Duncan Robertson to give us an update on where we are with the data.
Thank you very much. So as ever, we have relatively little data, but we can sort of talk about what data we do have. So really as a kind of summary, hospital admissions are low, but they are starting to rise. I suppose the relevant thing is the BA 2.86 variant, which still hasn't been classified as variant of concern, but as we found out today, it has been attributed to an outbreak in a care home. And as Christina mentioned, we're just about to start the autumn 2023 vaccination booster campaign in the next couple of weeks. And we've been told that surveillance will increase over the winter period, perhaps to respond to some of the new variants that are circulating. So in terms of cases and tests, this is from the COVID dashboard. The grey kind of mass there is the number of tests that are taking place. And as you can see from the right of the chart, we have very, very few tests taking place. And these perhaps are more biased towards people who may have COVID. And as we can see, the number of people who are positive, the percentage of those tests that are positive is starting to rise. Now, you know, the problem is we don't have that ONS sample, ONS survey. So these are biased samples, unlike the ONS survey, which was a survey of the population as a whole. So there's only a limited amount of information we can glean from that. One thing that is happening is sorry, I can't say it, water waste monitoring, but it's only in Scotland. And as we can see, there has been an uptick or an increase in the number of copies of COVID that have been detected, but we don't have this in England. So this is, you know, once again, just some of the data we have, not as good as the ONS survey. So maybe this is a reason why UKHSA are trying to increase the surveillance over the winter period. So in terms of hospital admissions, they are at a low level, but they are sort of starting to increase from that very low level that we had over the summer as we perhaps go into the winter period. But low level increasing slightly. But what we do have, and some of this information is relatively out of date, but we do have waiting lists for people waiting for diagnostic tests. So this is at June 2023, you know, 1.6 million people were waiting for diagnostic tests. So the pressure on the health system is increasing as we go into winter. Number of people waiting more than 6 weeks is, you know, 400,000. And number of people who are waiting a longer period than that, more than a quarter of a year or 13 weeks. So these are numbers that haven't gone down back to pre-pandemic numbers. So that's of concern as we go into this autumn and winter period. In terms of hospitals, we have, you know, millions of people waiting for treatment, which, you know, is a concern. We had a target of number of people who were waiting 18 weeks of referral, and that was very much below the target level there. Waiting more than 1 year, that peaked very much during the early period of the pandemic, but still at around 5% of those patients waiting for more than a year. The government put some targets into people waiting more than 18 months, and as you can see, that has fallen significantly. But that's what happens when you set a specific target. People will play to that target, but going back to that 12-week period, that's still at a significantly high level. So, you know, various targets can affect the number of people who are waiting severely long times, for example, over 18 months, but that's perhaps more as an effect of that target being introduced. Cancer patients waiting more than 2 weeks to see a consultant is higher than that target, and the number of people waiting more than 2 months to start treatment is still significantly higher than the target that was. And of course, the government can change these targets or remove these targets, but the data is still there. So, there is a concern building up. In terms of vacancies for the NHS, we have a significant number of vacancies in the health service, similar to number of people in the public sector generally. This is for nurse vacancies, and this is for medical staff vacancies. So there are still, these are pressures, indirect pressures on the health service as well. And I suppose one thing that we are starting to see is this autumn 2023 booster COVID vaccine. So this is the number of people before that booster campaign. And of course, what we have is a number of people who are waiting a long period, have waited a long period since the last vaccination. That would increase over the winter period. But of course, that's what this autumn booster campaign is to do, is to reduce those number of orange, that percentage of orange who are waiting more than 6 months. So for the most vulnerable in the population, they are going to be offered the opportunity to have a COVID vaccine. But the cutoff for the healthy population is over 65. So it's going to be a smaller number of people who are eligible for that autumn 2023 booster. And this is a similar figure for 75 to 79-year-olds. So in that age group, we expect the recency to, more people to have vaccinations more recently, because they will be eligible for that autumn 2023 booster campaign. Now, one thing that we have seen over the summer is the emergence of this BA 2.86 variant, which is significantly different to circulating differences. This is the technical briefing that came out yesterday. We're still not able to, UKHSA are still not able to make any assessment of that about the outcome of severity. But that will be monitored over time. And one of the reasons is that there isn't this surveillance that has been there up until recently. So UKHSA are going to start increasing that surveillance, perhaps to get better data to be able to look at these variants, BA 2.86 and other variants that perhaps may come as descendants of BA 2.86, to see what their outcome or severity is. So it's still not classified as a variant of concern. This is a variant of interest, but we're going to perhaps see more information in the weeks ahead. Now, one of the things that I suppose has been in the news today is there has been an outbreak in a care home in the east of England, I think in Norfolk, which has seen a significant number of people, residents in that care home, actually be affected with COVID. So 33 out of 38 residents tested positive with this BA 2.86 variant. But whilst that's a high, what we call attack rate, number of percentage who will be infected with COVID, the good news is 29 of those residents have recovered. 4 remain still unwell, though. And only 1 resident was hospitalised as a result of that illness. And thankfully, there have been no deaths from that outbreak due to COVID-19. So that's good news, but still we can see that variant transmitting in that population. And I suppose one thing to say is that the residents who tested positive for COVID had that spring booster around 4 months prior. So that's of concern. But as I say, few people were hospitalised and there were no deaths due to COVID in that care home. So good and bad news. And I suppose the other thing going towards winter is that UKHSA have said they're going to increase testing in England, partly as a result of that BA 2.86 variant, but just to see what's going on. So we are expecting that increase in surveillance, but we haven't really been told what form that will take. So it'll be interesting to see in the weeks ahead how that surveillance increases. So in summary, hospital admissions are low, but they are perhaps starting to rise. We have this new variant, which is significantly different to previous variants, still not classified as a variant of concern, but has been attributed to an outbreak. And the autumn 23 vaccination booster campaign is about to launch, I think 11th of September in care homes and 18th of September more generally in England. And I think the advice is to wait to be called if you are eligible for that. And UKHSA are going to be increasing their surveillance over the winter period. So that's the data for today.
Thank you, Duncan. So as I mentioned earlier, we're introducing a new segment now called the Situation Update, where you'll hear the latest about the research on the virus and where we are with regards to COVID. So today it's going to be led by Lennard Lee, and he'll be joined by Helen Salisbury and Sheena Cruickshank for that. So over to you, Lennard.
Thanks very much, Christina. I really appreciate that. And thank you, Duncan. It's fantastic to see all that data in one place. So what's the background to this? Well, the background to this is that at Independent Sage, you want to be able to shine the light for you on big issues that have come up. And Susan Mitchie said we should think about doing situation reports. So just 3 points and really your ability to get the expert opinion on that. So this is our new slide deck. I'm delighted to show you and run through our issues. So, number one, what have we noticed in the last few weeks? Firstly, the vaccination program has been moved forward. There's a new virus, as Duncan's noted, and the vaccination program is going to start on the 18th of September. We know who it's going to be, and I think Helen's going to tell you a bit more about this after I've got through the 3 items. But basically, it's going to be starting up for the vulnerable people and people above 65. The second point that we've picked up on, which is quite interesting, scientific advances. It's happening. Long COVID has clearly been an issue. We've been talking about it quite a lot. And brain fog is one of those issues. This is a paper that's come out, was covered by the BBC. It came out in Nature Medicine, so one of the biggest, most reputable journals. It's from the FOSS COVID Consortium, which is from Leicester and the University of Oxford. They looked at nearly 2,000 people trying to work out what caused cognitive decline. They did a MOCA test, which isn't a drink, it's a type of test to work out how well your brain's functioning 6 months later. And they tried to work out what's a risk factor. They found a few things. University education protects you against brain fog. Parkinson is a risk factor. But when they looked at people who had brain fog, they found the fibrinogen to CRP and the D-dimer to CRP ratio was up. So these are blood markers showing they've got problems with clotting here. So that's fantastic new understanding, which is where we're hoping to be with long COVID, because we need some development in this space. And finally, the last thing that I'm going to touch on here came out just a few days ago. We're going to scale up testing. The UK have done really well in terms of having this network of laboratory with really skilled people, with automation, robots doing the PCR tests. In January, we heard that they're going to scale it down. So the Rosalind Franklin shut down, but we're going to hear that we heard that they're scaling up now in response to the new variant. So I think that's good news, responding to demand. So that's the 3 things we picked up on, but I'm going to pass over to Helen because she's got some updates too on these points. Helen, over to you.
You're muted.
Bit rusty coming back.
Apologies. I just want to talk a little bit about vaccines and where we are. And I think it's fair to say that GPs are at 6s and 7s over vaccines at the moment. So in the middle of the summer, about the 8th of August, GPs were asked, please don't start your vaccination campaigns for flu. There's a kind of assumption we'll do flu and COVID at the same time so we can get people in just for a one-stop shop. Please don't start till October. So lots of people rearranged their clinics. And then on the 30th of August, we were told, no, please start vaccinating really, really soon. And in fact, it's the 11th that the campaign is going to start with the most vulnerable people in care homes and the housebound. So there's a lot of scrabbling around now to try and get these campaigns working as soon as possible. One of the thoughts was that we were being asked to wait because there might be a new vaccine coming on stream, and in fact it's just been licensed, but then then the Parola BA.2.86 came on stream, and a worry that we should just get on with vaccinating as soon as possible. I'm going to ask Sheena in a minute just to talk about the different vaccines and the different viruses, because it's quite complicated. Anyway, the state we're in now is that the vaccine program will start with the old Pfizer vaccine, the bivalent Pfizer vaccine that we were using in the spring, and it will start on the 11th for the most vulnerable, and then the 18th for everybody else. The everybody else is just the over 65s, the clinically vulnerable, and health and care workers. So that's a lot of people who previously had vaccines who won't get it. There are all sorts of other problems going on to do with everyone was the booking systems aren't going live for a while, and we're meant to be putting the flu vaccines and the COVID vaccines on the same software system, which won't accept them yet. And the technical problems are causing a lot of headaches. But from the patient's point of view, you should hear from your GP practice if they're offering vaccines. There's a slight fly in the ointment that earlier in the summer, there was announced a reduction in payment for giving vaccines, and quite a lot of practices and PCNs decided that they weren't going to do the COVID vaccines. That's been reversed since, but there's still a bit of a gap in who's going to be providing vaccines. From the 18th, there will be a national booking service rolled out where it'll be possible to book in pharmacies if you are eligible, but that's going to be quite, it's going to be interesting to see how we manage to cover everybody. And we don't, certainly in our area, we don't have a mass vac centre this time round. Now, what I've said comes cover, that's England. I think Scotland's got things maybe slightly better organised, they do things differently there. But in England, certainly, it's a little bit of a scramble at the moment in general practice. We hope that those of you who are eligible will get a communication from your GP practice soon. I'm going to hand over to Sheena, if that's all right, just to fill us in on the which virus, which vaccines, what's going to work, what do we know?
Thanks, Helen. Yeah, I think Scotland are starting a little earlier for their vaccine booster programme than England, and I think Wales is following suit with England as far as I can tell. So what is the situation? Well, we've got several variants around at the moment, so we still have a bit of a variant soup. And the one that's been really worrisome, I think, recently is this one that's been nicknamed Parola. And that's because it's got over 30 mutations in it, including mutations that look to make it more immune evasive. And some of those studies have now been done in the lab. There's been about 4 or 5 preprints out now assessing whether or not it will indeed be able to evade our immune system a little bit better. And unfortunately, it does look like it can evade our immune system better. In all the studies that have been done, it's better able to dodge our antibodies. However, it seems to be less able to dodge antibodies generated by the XBB strain that sort of started circulating around January. Now, that's good news if that's the booster that you're getting, and certainly in America, that was the one that they've gone for. However, in the UK, it looks like the decision was made to stick with existing stocks. Now, that's not to mean that they're not going to work. They're still way better than having no vaccine at all, and they will also provide some protection against the other variants that are circulating. And I've written about this in an article out today, and we'll post the link later. Christina.
Right, so with that, we're going over to the main bit of the session, which is discussing going airborne, and that's going to be led by Prof Trish Greenhalgh and Dr Binita Kane. So over to you.
Right, thanks very much, Christina. And as Len has already said, in this autumn series, we're going to have a number of presentations. This one's on airborne, where we look back at what's been going on in the last 3.5 years and forward with the lessons that we've learned from the pandemic so far. And in this session on going airborne, the question that we're going to address is, what have we learned about airborne transmission of SARS-CoV-2, and what are the implications for preventing transmission of airborne infections? I want to take you back to the 8th of March 2020, 5 days before the WHO declared this a pandemic. There was a beautiful concert of the St. John Passion by Bach, and of a choir of 130 people. This is just the choir, never mind the audience. 102 became infected with COVID, and 4 people died. 1 member of the choir died, 3 partners of choir members. So this was a huge, one of the earliest mass infection events. And from that point on, I was pretty convinced that this virus spreads through the air and perhaps is spread by singing. The WHO didn't agree. 28th of March 2020, this now infamous tweet, the so-called fact check, they put out this very emphatic statement that COVID-19 is not airborne. This was a false level of certainty. They actually didn't know. They called it fake news. And 2.5 years later, the departing chief scientist of the World Health Organization, Dr. Soumya Swaminathan, was asked what her biggest regret was. What was the WHO's biggest mistake? And she said, "We were not forcefully saying this is an airborne virus. I regret we didn't do this much, much earlier." Let's just remind ourselves about the difference between droplet infection and airborne infection, or droplet spread. And I'm not a kind of technical expert on this, but there's a common sense aspect, which is a droplet, almost by definition, is something that drops. It isn't suspended in the air. It drops due to the force of gravity. And what that means is most of those droplets are going to be spread in very close contact. Of course, if someone sneezes in a projectile way across the room, they may travel more than 2 meters, but mostly we're talking about close contact. It is very important to note, however, that airborne transmission also occurs mostly within 2 meters. If you think about the person who's smoking a cigarette, or for example, if you're very close to them, you're going to inhale more smoke. But if you're the other side of the room and they've been in there for a while, exhaling their smoke, you're still going to pick it up the other side of the room. So that's the kind of mental model we need to keep in mind, because a lot else follows from that. Now, I'm not going to take you through today the evidence base, but I'll flag up 2 papers. The first paper here is one that we published in The Lancet in 2021, 10 different streams of strong, consistent scientific evidence, which showed that the SARS-CoV-2 virus was predominantly airborne. And a paper published towards the end of 2022, which demonstrated that basically policy ignored that evidence and operated on the assumption that spread was not airborne. And an awful lot of bad things followed from that. Now, I hope this is familiar to many of you, but it's nice to revise it. The prevention policy that was followed and often is still being followed with so many organizations. You walk into a supermarket and what's the policy? You go to work, what's the policy? The Red Crosses mean there is no evidence that this prevents the spread of SARS-CoV-2. There is no evidence that hand washing actually has any impact on the spread of SARS-CoV-2. I'm not saying it's a bad idea to wash your hands. I've had children. There's other reasons to wash your hands. It's a very good idea to wash your hands, but there's no evidence that it prevents transmission. Similarly, scrubbing those surfaces. Physical distancing does prevent the spread, but maybe that's because a lot of that close contact spread is actually through the air. Face shields and perspex screens. I went into my local pharmacy the other day and there was this perspex screen, just a kind of 1 meter square. There's no evidence that it prevents transmission. Isolating only if you're coughing or sneezing. Of course, it's a good idea to isolate if you're coughing or sneezing, but actually, because quite a lot of spread is from asymptomatic people, you don't just have to isolate if you're coughing or sneezing. You have to isolate if you're contagious. Waterproof masking if you're only wearing those masks within 2 meters, which is what the standard recommendations have been for a long time, there's no evidence that that prevents the spread. You have to wear the masks a bit more consistently. And finally, all that stuff about aerosol generating procedures, the idea that the doctor would take off the waterproof mask and put on one of those special respirator masks just for the aerosol generating procedure, no evidence that that helps. So now let's look at what follows from the mechanism of transmission, which is this virus is suspended in the air. And the first thing we need to note is that people may be asymptomatic but contagious. When you're sitting on your bus, in your tube train, nobody's coughing, nobody's sneezing, everybody looks healthy, that air may still contain virus. It may contain virus even if there's nobody in the carriage because they've breathed it out before they got off. Second thing, we need to limit the amount of time that is spent indoors, because this is not about what we call the single ballistic hit. You get the droplet in your eye. It's not about that. It's about continually breathing in air that has viral particles in it. So the shorter time you spend breathing in that kind of air, the better. And that's especially true if it's crowded with lots of people. Thirdly, we need to ventilate our buildings and or filter the air in them. And again, I'm not going into the technical detail here, but one of the big omissions of the pandemic is that all that dropped to a much lower priority level than it deserved. Physical distancing, I've said there is evidence. Everyone wearing well-fitting respirator masks indoors. Now, I'm not going to say that we should all be doing that all the time, but if the only factor was prevention of transmission, that is a very effective way to prevent transmission. And finally, avoiding activities indoors involving singing, shouting, and heavy exercise. And again, we have to make those choices, but purely from the transmission perspective, the science is on the side of doing that. Some of you may remember this chart that we produced for a BMJ paper back in 2020. We subsequently published a paper quantifying these estimates. And I'm going to talk you through it. If we go up to the top left-hand corner, that top little green rectangle, what we're presenting here is the safest situation to be in, which is out of doors, obviously well ventilated, not saying anything, not puffing and panting, and wearing a mask, and you're only in contact with someone for a short time. That's really, really safe. You're very unlikely to catch COVID, even if they've got it. And now if I take you right down to the bottom right-hand corner, that little red lozenge is thousands and thousands and thousands of times more risky than the top left. And that situation down the bottom there is, first of all, when you're not wearing a mask. Second of all, when you're indoors. Third of all, where it's very crowded, it's high occupancy. And fourthly, when you're puffing and panting and shouting and singing, that is very, very unsafe. And all the mass infection events support this as a very useful model to assess your risk. Now, one of the riskiest situations to be in actually is in the gym, where everyone's puffing and panting. You might be in there for an hour or so, depending on how well ventilated that gym is. And some people have been working with their gyms, some people are working with their churches and cathedrals and things to say, can we please monitor the carbon dioxide levels? And that's a pretty good proxy for just how much expired air is in the air that you breathe in, provided the air isn't being filtered. If it is being filtered, it doesn't filter the carbon dioxide. And so the readings might be high, but actually it isn't all that unsafe. But apart from that, the CO2 is a pretty good indicator. What you want is a lot of air changes per hour, the ACH. And it's actually quite technical how many air changes per hour are needed. And again, I'm not going to go into that now, but there's a little, you can see that the hot link. I'm not going to risk clicking on that hot link, but this actually calculating, put in the size of the room, what people are doing, the air change per hour, and then they'll tell you the risk. So there's a lot of ways you can calculate how risky it is going into that church or that gym or that whatever it is. So now I just want to talk about where these precautions, kind of where the responsibility lies. The thing about droplet precautions are they're mostly about individual behavior. Wash your hands, cover your face when you sneeze, scrub the surfaces, wear a mask, wear a shield, etc., etc. It's about what individuals do. But actually, airborne precautions need action from employers and from governments. We need safe buildings. We need to keep our employees safe. We need to keep our customers safe, our patients safe. And I say that as someone who lost a parent to hospital-acquired COVID. I'm going to ask Steve to comment a little bit about health and safety when I've just finished going, or when we've finished going through these. Some people are saying masks don't work. Actually, there is very strong, consistent, definitive evidence that masks do work, except in certain conditions. Masks, guess what? They don't work if you're not wearing them. They don't work if you're not wearing them all the time when you're indoors. Masks don't work if they don't fit you with a good seal around your face because it's an airborne virus and it'll go in around the edges. Masks don't work very well if they're made of the wrong material, but actually any mask is better than no mask. So if you've only got a kind of cheap cloth mask, it's better than nothing. And masks don't work if you keep taking them off, because you'll then be exposed to the air. So made a myth buster on that one. There is lots of evidence that respirator grade masks for all staff in health and care settings, it reduces the transmission of COVID. There have been randomized trials of respirators versus medical or surgical masks, but those studies were flawed because the respirators weren't worn all the time. They were only worn during aerosol generating procedures. So that evidence it's highly contested. People are confused by it, but actually, if you keep the mental model of the science in mind, it's very clear what the problems were with those studies. This you may recognize as a DIY filter. It's a Corsi Rosenthal box. It consists of a cheap fan and a load of filters. You can knock one up. There's the DIY instructions. And actually, Binita's going to tell you about those in a second. And then just to flag up a sort of learning from the past idea that right back in 1942, they were reducing the transmission of tuberculosis in school classrooms by using ultraviolet spectrum radiation to kill the airborne pathogen. And that's coming back. That's it's a sort of research level piece of work at the moment, but I think we should be watching this space to see what happens. And now I'm going to show you this lovely picture from last week's New York Times. I love the title, COVID closed the nation's schools. Many of you have sent your kids back to school this week. According to this, cleaner air can keep them open. So the emphasis, I think probably rightly, is moving away from arguing about whether or not we should be making kids wear masks to school and talking much more about ventilation in schools. And now I'm going to hand over to Binita, who's going to take us through a nice little positive story about clean air for schools.
Thank you, Trish. And that's a great background to kind of explain why we've done what we've done. So I just wanted to talk about a project that we've done locally that's been very much, the heavy lifting has been done by Layla Williams, an amazing ex-NHS leader who has led on this with my support. And we've been supported by the public health team at Warrington Borough Council, who we engaged in this conversation in September 2021, when I was really concerned about my kids going back to school and not being safe. Next slide. So clean air is important in school for reasons other than COVID. Actually, there's huge evidence base about the damage of indoor and outdoor air pollution. So schools that are near busy roads, there's lots of evidence around how that's damaging our children. So if you've got clean air in school, it's estimated to be worth an extra 6 weeks in school each year in terms of improved health for our children. Reduce sickness rates, which is for teachers and children by removing viruses, reducing sickness and absences, etc. And in terms of health, we know air pollution kills millions of people across the globe every year. And so clean air will improve our respiratory, cardiovascular and neurological function and health. And teachers were struck with long COVID, only second to health and social care staff during the pandemic. And so the teaching profession, as well as healthcare profession, have been particularly hard hit by the impact of not having clean air. Next slide. So our proposal that we took, and there were various other names on the front of the slide. I should have given a big shout out to Michelle Wong and various colleagues who've really helped support us with this. But we proposed that we would do a project in schools, which was around the children doing this as part of a STEM project. So they would learn why clean air is important, as they learn about the science. Hopefully it might inspire them to get involved in STEM as a career. They will learn about the physics in terms of ventilation and filtration, and they can have some fun building air filters. So we were supported to do this in a couple of local schools. Next slide, Trish. Thank you. And our ambition was really about not just having the clean outdoor air, but having clean indoor air. Next slide. So this is Layla here on this photograph, and Mr. Thompson, who's a head of science at my daughter's high school, and myself, and we were delivering the filters and the fans here for the STEM Club project. The funding for this, so the Corsi Rosenthal boxes that Trish has talked about, cost about £150 each, and that's mainly because you have to import some of the components. And I know Layla and colleagues are doing a lot of work as part of the Jim Rosenthal Foundation in the UK to make this much more available to schools. So Layla was able to get some funding from a local recycling business called Novelis, who funded enough for us to build 20 or 30 of these. There was also support from the Science and Technology Facilities Council, and we're working with 2 high schools and 2 primary schools. So the high schools are underway, primary schools are just getting started, but they've got some really brilliant plans around year 5 doing air quality projects, having an exhibition, teaching the preschoolers about clean air, and then building DIY air filters. So where are we up to? The STEM Club's up and running. To date, more than 30 clean air filters have been built by the kids. It's linking up with other projects, and particularly SAMI, which is the school's air quality monitoring for health and education. So actually, if you engage your local authority and your public health department, you're helping them tick their air quality boxes as well, because they all have targets around that. We are looking for more funding opportunities. So please, if you're watching this and you want to get involved, do get in touch. And I think it just shows where there's a will and the right engagement and the right support and a very small level of funding, there is a way to do this. In the my daughter's primary school, we actually crowdfunded and got kind of commercial HEPA filters put in. And I have to say, since they were put in, which it's easier in a primary school, there has not been a single big outbreak in any class. So there's been individual cases. So anecdotally, it does work, but there is evidence-based to that effect as well. So I'm going to finish there and hand back to Christina, I think.
Yes, Christina. It's Christina.
Yes.
Back to you, Christina. Actually, we're going to pass to Steve, aren't we? Is that right, Christina?
I have got, yes, that Steve right here.
Steve's going to comment on health and safety.
I am. Okay. Well, first of all, hello everyone. It's nice to be back after the summer. Although living in Scotland, I might as well say what summer, but still. I think Trish has given us a really powerful and coherent argument about the way in which the wrong model of COVID and COVID spread led us to estimate the risks in the wrong way, which made us think about the mitigations in the wrong way. And she's emphasized, and I think this is true more generally about the pandemic, that we've emphasized the individual and individual responsibility and individual blame and ignored the systemic issues. And in many ways, one of the most important things we can do is to make environments safe and to make workplaces safe. Now, of course, there is legislation which obliges employers to keep workplaces safe. Health and safety legislation says that employers have got to do this as a matter of law. But of course, the law is meaningless unless you've got mechanisms for making sure the law is upheld. And that's where I think there's a really big scandal that we haven't paid enough attention to. And that is the failures of the health and safety executive and the health and safety investigations during COVID. See, again, the emphasis was at an individual level. In the first year of COVID, over 100,000 individuals were fined for breaches of the regulations. When it came to workplaces, there were only 78 enforcement notices and not one single prosecution. Nobody was prosecuted for health and safety breaches, even though 40% of cases had contacts in their workplace. So virtually nothing was done to uphold the law. Now, the reason why is quite simple. It's that the health and safety executive and health and safety inspections have been completely atrophied during the period of austerity. Between 2010 and 2017, the number of local authority health and safety inspectors fell from over 1,000 to just over 500. In the entire country, there are only 390 health and safety inspectors who are at the higher level. And as a consequence, the HSE did not do any spot checks. It didn't go and check up workplaces. What it did was to do 15-minute telephone interviews. So, of course, they couldn't find where there were violations. And, of course, they couldn't uphold the law. And so, of course, we had spread in workplaces. And now we're going to talk a lot over the coming months of the things we've got to learn and do in the future. And of course, we're going to stress that the NHS has got to be prepared and properly funded. But I think just as important, it should be a key demand from all of us. We've got to have an effective HSE, Health and Safety Executive. It's got to be properly funded. In the 10 years before the pandemic, it lost £100 million. It's got to be properly funded, and it's got to do spot checks to make sure that environments are safe, because that's a key issue in stopping a future pandemic.
Thank you. And here as well. So yeah, thank you for that, everyone. That was great. So now on to our Q&A section, and we're going to start with Flora Palmjit, who's managed to join us in person. So Flora, would you like to unmute and ask your question?
Yep, absolutely. Thank you. So just given that there's been some relatively serious talk of having COVID vaccines that are purchasable, and obviously I'm sure we'd all prefer them to be free for all adults and children, but that looks unlikely. So if we assume that money is no object, is there an optimum number of vaccinations that I should aim to get per year if I'm lucky enough to purchase them? And how does that number change for a non-CEV person and a CEV plus pregnant person like me?
Great question. So would anyone like to answer? Sheena.
I'll say a little bit about this. I mean, I think at the moment, the advice would be around the lines of looking at sort of annual boosters for the types of vaccines that are available. I would be hesitant and I would be doubtful whether they would be available for the vaccines that seem to be currently or have been currently available in the spring season, because that is for the most clinically vulnerable. The reason we sort of look at the most clinically vulnerable in separate ways is because these will be people who may have, for example, less effective lymphocytes, which are the things that you need to make antibodies, or the T cells that help support antibody function and help kill viruses. And they may even have fewer numbers of those. And so the vaccines may not work quite as well in these sorts of people. And these are often the people that we see that are most susceptible to sort of, you know, the bad effects of COVID. So I think that's why we kind of look at that. So I mean, I'm worried about this idea of making it, you know, purchasable, because I think that brings in huge health inequalities. And I really hope if it does become available commercially, that they will look at sort of keeping the costs manageable for people and maybe helping with the costs for some people, for example, people who are eligible for free prescriptions.
Thanks. Len, you wanted to add something?
Thank you, Christina, and thank you, Flora, for bearing witness to that, because it is a really good question. People speak up for vulnerable people deserve thanks, basically, for your community. I'm going to go hard on this point. We should not ask people to pay for protection. You should, if you're vulnerable, you should not have to pay for protection because the virus is spreading in the community. So I think that's the first point. If we're going to protect everyone, we should not be penalising the most vulnerable through financial means. And the second one is, you asked the question, how does it work? How often should we have it? This requires data. And I think we've been saying this quite a lot. So many of us have been saying, actually, we need really good data programs. And the more that we have, the more information we've got. And I guess the wider point here is, how are we monitoring vulnerable groups? Can we do more about this? And to repeat that core, keep an eye on the numbers, use data to improve health. But these are fantastic questions, and thanks for bringing them.
Steve, did you want to add something? Steve Griffin, particularly anything on spacing?
Sure. Well, on spacing maybe, but I think this really highlights one of the challenges and understanding about these vaccination programs, because what we've been trying, what the country has tried to do is sort of force a kind of flu influenza model on the vaccine program, which is very different. So in flu, we see those flu strains coming every year. We can plan for them and we tailor those vaccines accordingly. With SARS, what we're doing is we're kind of behind, and we've got vaccines which work against strains that were designed against strains that were several months hence. Now, the other element of that is that really is most important if you're talking about protection versus infection, as opposed to the severe form of COVID, severe disease. Now, your protection against infection, because the virus changes so much and evades antibodies, wanes much more quickly than the protection against severe disease. So when people are talking about, oh, this vaccine's not going to work anymore, they're not really talking, and you shouldn't be talking as black and white there. And it's just really important that if you're clinically vulnerable, that you keep maintaining that protection against severe disease, as well as the antibodies. So I would suggest that these biannual boosters should be adopted by everybody who is offered one as a vulnerable person. And ideally, we should be trying to suppress prevalence, because that's the only way we're going to catch up in terms of designing these vaccines properly.
Thanks. So I hope that answers your question, Flora, as much as possible. The next question is from John Wardle, who's written in. We heard from Sheena earlier that the initial vaccine rollout this autumn will be last year's booster, which contains the original Wuhan strain and Omicron BA4 or 5 spike. And so John's question is, he says, my understanding from last year was that the inclusion of Wuhan original strain could lead to imprinting, and that can lead to an inappropriate antibody response. And the WHO actually recommended that future vaccines should not contain the original spike protein from the Wuhan strain. So what are our views on taking up this vaccine, and what is the evidence on the effectiveness of it against current strains? So I'm going to start with Sheena and then open it to everyone else.
Yeah, that's a really interesting question. And imprinting's a really important concept, actually. It's this idea, I think it was sort of really first discovered around kind of the flu pandemics, where your immune system gets trained to recognize sort of a particular feature of a virus or a bacteria, whatever it is. It's usually viruses, though. And if that virus then changes, your immune system becomes a little bit less able to flex and change. And there is this idea then, or concern, that if we keep training our immune system to respond to the very original strain of COVID, our immune system is not going to be quite so good at dealing with these constant changes that the COVID virus seems to be keep throwing at us. And, you know, there is some data that is showing that there is imprinting happening, and Danny Altman published an absolutely beautiful study, I think it was earlier this year, that showed that imprinting was indeed occurring. However, it's not really clear whether we're ready to completely shift away. I don't think we necessarily need to have, that's my personal perspective, that we don't necessarily need to have the original strain in our vaccine packages anymore. But certainly there is some protection being offered by the current offering in vaccine. And I think if you're clinically vulnerable, it's really critical that you take it, because otherwise you are left with no protection at all. But maybe moving forward, we will see a tweak to designs to vaccines. But there are reasons that might also be a bad idea. And I suspect Steve's going to say a little bit about that.
Well, actually, I'm tempted to move on because we've just got a few more questions. So, Stephen, is there something that you specifically want to add to what Sheena said?
Just very quickly to say that the only issue with following the virus and the way that the vaccines have been is that you can get caught off guard, and the BA.2.86, the pyrola emergence is one example of that. So if you chase the vaccines too far down one road of virus evolution, there is a chance your immune system will follow that, and then you may be not quite so well prepared against random variants that pop out from nowhere. But it's a difficult one to gauge, because you've obviously got to address the immediate clinical need.
Thanks. And just to add to that, Steve put in the chat that for people who are pregnant, the optimal time to get your vaccine is your 3rd trimester, because then your baby also gets protection from the antibodies. So just putting that in, because I think that's important information. And it's very safe in pregnancy as well. The next question comes from Polly Neary, and they say that the CDC has stated that with the new variant, peak infectivity occurs 24 to 48 hours before symptom onset. I think that was true actually for all COVID. How can it be right that medical staff are no longer wearing masks and are told to work if they are well enough? What happened to first do no harm? And is there a way to challenge this when you're going to your GP or into hospital? So does anyone have any thoughts on this, particularly those who I know are working in those settings? Helen, and then Trish.
Yeah, I think this is a really difficult situation, because on the whole, it's very difficult to ask the public in general to wear masks. In our surgery, we ask people who have symptoms to wear masks, but as this questioner so rightly points out, that may be too late. At the moment, we are able to keep all our windows open and keep the air circulating and hope that we reduce our infectivity in that way. And of course, we're very happy to put masks on if our patients want us to, but it's very difficult for healthcare workers to go against the tide of being told all the time you don't need to be wearing masks and your patients don't need to be wearing masks. We carried on in this surgery a long time after everybody else, but even now we're not wearing them routinely. I think that might change. I think as a vulnerable patient, to wear them and to ask your clinician to wear them is also a good idea, but it doesn't necessarily protect completely in the waiting room. We'd rather everybody else was wearing them too, and that you had some guarantee about the air quality in the settings that you're going to be waiting in. Sorry, that's not really a very good answer, but it's the best I can do.
Trish?
Yeah, should I come in? This is a really, really difficult issue, because policy is following a droplet infection assumption. The mode of transmission is assumed to be droplet, and everything is following from that. And therefore, the thing that we've got to do is change policy and change the way policymakers think about this. And that is not an easy thing. John Snow, when he was trying to persuade policymakers about the spread of cholera being waterborne, actually took 13 years after taking the handle off the water pump and people demonstrating the science of waterborne infections. It took 13 years, and I rather suspect it's going to take a similar amount of time. So that's one thing. There's two things to think about here. Why do we wear masks? I wear a mask partly to protect myself, and I wear it partly to protect you, because if I'm asymptomatically infected, I'm going to be exhaling that virus into the air, and that's not good. Now, if we're in a situation where people are not wearing masks, most people are not wearing masks, the way to protect yourself is to make sure you are wearing a respirator grade mask. there is a crazy situation going on in some hospitals where you can turn up wearing a respirator mask, but they then make you take it off and put a lower quality mask on, one of those surgical masks, because they don't like the look of your respirator mask, and they say we must wear one of ours. And that's a big problem, because the surgical mask doesn't protect you because it's got gaps around the edges and all that kind of thing. And if you're vulnerable, that's a problem. And I will put a link to a paper that I wrote called Downgrade Your Mask Before Entering This Hospital, and what a crazy policy that was. It's still happening. We're still putting pressure. We're still writing academic articles on it. But yeah, there is no simple solution to this. I think it's all about continuing to work locally, and also to put pressure on the policymakers. But yeah, the person who's pointed this out is right. It is crazy.
Thank you. So the next question is from Deborah Dyer, and she says, I tested positive for COVID this week. How do I report this so it can be added to the current figures? And the answer is, assuming it's lateral flow test, that if it's a free NHS test, you can upload it on the UK HSA website. And if it isn't, if you bought it from a shop, you cannot report it. So that is a big limitation of the numbers, because if you bought tests, and most people are now having to buy tests, you cannot report positive results. The final question is from Sheila Spooner, and she says, I'm interested in ventilation on local public transport and in swimming pools. Is there any research to give us a rule of thumb about the effectiveness of the ventilation in different settings? One professor said it's preferable to travel by bus instead of train because you can open the windows. But somebody else said the advantages of trains were that they had mechanical ventilation. I'm confused. And does the warm, damp atmosphere in a swimming pool help or hinder the spread of virus? So I'm first going to go to Trish as a keen swimmer, even though I know you prefer to swim outside.
Yeah, I normally swim in the river, certainly for this time of year. I am not currently very up to date on swimming pools, but the last time I looked, there wasn't a lot of evidence that you catch COVID when you're in the swimming pool. Certainly, I went to the swimming pool a few months ago, and they said when you're swimming up and down, you have to maintain 2 meters distance from the person ahead of you. That's just crazy. I mean, it's a good idea to maintain 2 meters distance, but the idea that physical distancing or social distancing should be practiced in the swimming pool, that's no good. That calculator of air quality, which I showed on the PowerPoint, we'll put a link to that. I don't think it's as simple as, oh, it's trains better than bus, because it depends on what's going on. Some trains are well ventilated and some aren't. Some buses have windows you can open and some don't, all that kind of thing. But certainly if I was in public transport, because it is a small space, most of these carriages are smaller, you know, they've got low ceilings and things, it's a small volume, I would be wearing a respirator on those. And it actually, if I'm on the train, I will wear a respirator from when I get on the train to when I get off. And I won't buy a drink because I then have to take my respirator off, because I think that air is very viral laden.
Okay, thank you. So we've got 2 minutes left. So I'm just going to see if we've got time for this last question. It's from Katie, and it says, she says, what is the best approach towards recovery? The message we get so far is my 12-year-old needs to think more positively and get back out of her wheelchair and be more active. She also has connective tissue disorder and scoliosis, and this seems like it causes more damage, not progress. So I think this is about long COVID. She's had it for nearly a year with no improvement with this approach. Should schools be offering support such as virtual access rather than pushing students back to in-person school while recovering from long COVID? And I think I'll go to Binita with this question.
Yeah, really important question. And again, a very difficult area, because I think there's very poor understanding still amongst education staff, schools, some primary care professionals, some healthcare professionals around what long COVID actually is. And it's under-recognised in children as well. So absolutely the mantra of pushing through and getting back to exercise is harmful. And there has to be education around careful pacing and children working within their energy envelope. And they can learn. So with children with long COVID can learn. The school environment's often the wrong environment for them because it's noisy, it's loud, they're at risk of reinfection. And they can't often concentrate for long periods. So I think my advice would be have a look at the Long COVID Kids website. There's lots and lots of support on there. There's a pack for schools. There's advisors on there who can give you advice. There's forums where you can speak to lots of people who are in the same position. In 1 minute to go, I can't cover all of that, I'm afraid, but it's a really great resource looking on the website.
Thank you. That is actually really helpful. So I think that's all the time we have today. So thank you again to Trish and Binita for the main session on airborne spread, and to Sheena and Len and Helen to kind of give us the situations at the beginning, and Duncan for the numbers, of course. So we'll see you all in a couple of weeks, and we'll be discussing resilient healthcare systems. So have a good few weeks, everybody. Bye.